Doctors, we are live.
Good afternoon, everyone, and a very warm welcome to all of you. My name is Deepa Chakola, and I am the course coordinator for this CME series. It is my honor to introduce Dr. Ekta Shah. She is an associate professor and pathologist at the Department of Pathology with the Neuro-Oncology Disease Management Group at the Tata Memorial Hospital, Mumbai. Dr. Shah has done her MD at the Tata Memorial Center and thereafter worked as senior resident in histopathology. She's also been assistant professor in pathology at the Geetanjali Medical College in Udaipur, Rajasthan. She has also trained in flow cytometry and molecular pathology at the Rajiv Gandhi Cancer Institute and Research Center in New Delhi. She's also done her fellowship in surgical pathology at the Tata Medical Center in Kolkata and also a master of research in translational cancer medicine, which she passed with distinction from King's College in London. She has also participated in various seminars, presentations, interdepartmental academic meetings, and has many awards to her credit. Dr. Ekta is also part of the Traveling School of Pathology and Surgery under the National Cancer Grid program and has traveled to many cities for the same. With her vast experience both in clinical and teaching fortes, today's lecture is going to be a delight for all of us. Over to you, Dr. Ekta.
Thank you, Dr. Deepa. I'll be sharing my screen now. Good afternoon, everyone. Is my screen visible, Deepa?
Yes, Dr. Ekta.
Okay. So, overview of lab investigations in cancer diagnosis, tumor markers, cytology, and histopathology. It's a very broad topic for 1 hour, but I will try to do as much justice as possible. So, within this limited period of time. So, let's get started. So, I begin with the tumor markers. I'm getting the host has asked you to start your video. So should I click that, Deepa?
Yes, doctor, please turn on your video.
Okay. Okay. So yeah, so beginning with the tumor markers. So my slides are not moving. Let me start share again. Okay, not moving. Sorry for that.
No worries, Dr. Ekta.
Can you see my slides now?
Yeah, we can see your slides.
Okay, is it moving?
Yes, it is.
Okay, thank you so much, Deepa. So, okay, we begin with the tumor markers first. So what is a tumor marker? It's anything which is present in or it's anything which is present in or produced by the cancer cells or other cells of the body in response to cancer, or they can also be produced by certain non-cancerous conditions. So what are these tumor markers and why are they used for? So these are basically important tools to suspect a diagnosis of cancer, aggressiveness of the cancer, making making treatment decisions, monitoring therapy, and finding a recurrent tumor to see whether there is a recurrence of a tumor. What are these made of? These are proteins or other substances that are made up of at higher amounts by cancer cells than the normal cells, and they're associated with one or multiple types of cancers. There are two main types of tumor markers. They may be circulating tumor markers or it may be tissue tumor markers. Now, what are these circulating tumor markers? Circulating tumor markers can be found in the blood, urine, stool, or other bodily fluids of the patient with cancer. And as I've already said, what are the uses of tumor markers? The same applies to the circulating tumor markers also. Now, what are the examples of tumor markers? An example of tumor marker is calcitonin, which is used to assess treatment response, screen for recurrence, and estimate the prognosis in medullary thyroid carcinoma. CA-125, which is used to monitor treatment response and to ascertain if the cancer has recurred in ovarian cancer. Beta-2 microglobulin, again, which can be measured in blood, urine, or cerebrospinal fluid, and it is used to estimate the prognosis and follow response to treatment in various tumors like multiple myeloma, chronic lymphocytic leukemia, and some lymphomas. Now, coming to tissue tumor markers, I will elaborate these tissue tumor markers further in my section for immunohistochemistry. But just to introduce them, these are found in tumor themselves, typically in a sample of the tumor that is removed during a biopsy, and again, which is used to diagnose or stage or classify cancer, estimate the prognosis, and select an appropriate treatment, that is targeted treatment or personalized treatment. Now, in the tissue tumor markers, they indicate the potential candidates for a particular targeted therapy, as I have already said, and they're sometimes referred to as biomarkers for cancer treatment. Examples of these tissue tumor markers include estrogen receptors, progesterone receptors in breast cancer, FGFR3 gene mutation analysis, which helps to determine the treatment for patients in bladder cancer, PDL1, which is used to assess candidates for treatment with immune checkpoint inhibitor therapy. These are some of the examples of tumor markers, which may be hormones or oncofetal proteins, enzymes, isoenzymes, epithelial markers, specific proteins, mucins, and a wide range of tumor markers can be produced in a host of tumors. Not only by one cancer, maybe multiple cancers may produce the same tumor marker as well. So I will be elaborating more about the biomarkers in my IHC section. Coming to the next part, that is cytology. Cytology, there are a host of samples which we receive in our cytology section, which may range from FNAC, liquid-based cytology, cell blocks, exfoliative cytology, and all the host of other conditions. But I'll speak more in detail about a few of them, which are more commonly received in many of the centers. So the first one will be FNAC. So fine needle aspiration cytology is, as we all know, is a quick, simple, and inexpensive method which involves using a thin, hollow needle to remove samples of cells from tissue or fluid in an organ or a lump. FNACs can be performed by qualified and trained personnel. The person may be a clinician, a surgeon, a pathologist, or a radiologist. And the procedure is very simple. It can be performed in an outpatient basis, and it is just need to immobilize the lesion, sterilize the field, penetrate the lesion, create a vacuum, obtain material in changing direction, and finally preparation of the smears. And for richly vascular lesions, we should not use the aspiration technique. So coming to something which is important and which may not be practiced in many of the centers is rapid on-site sample evaluation, which is also known as ROSE. Now, what is this ROSE? So generally for image-guided FNACs that we usually perform in case of breast cancers or thyroid tumors or lymph nodes or any abdominal lesion, that is the USG-guided FNAC, or CT-guided FNAC, which may be performed for lung lesions, any chest wall lesion or spinal lesion, or any lesion in the kidney. So for these lesions, it is very important that we know whether the sample is adequate or not, then and there. Otherwise, the patient has to be reposted for the procedure, and the procedure has to be repeated. So in order to avoid all these things, it's important that we know that the sample is adequate at that very moment. So how do we do that? So there is a process by which we assess the sample then and there for adequacy, and for ancillary testing, we separate the smears out, and that is what is known as rapid on-site sample evaluation. So how is it done? So rapid staining is done for adequacy of the cellularity, and you need to fix the smears in ether alcohol for 30 to 45 seconds, and then stain with toluidine blue for 10 seconds. Wash the excess stain, mount with glycerin, and check for the adequacy. So if you see that the cellularity is adequate, it's not important that you make a diagnosis there, but it's important that you need to see that the cells are there, which and that sample is adequate or not. That is why we do this procedure, which is known as ROSE. Now, processing of FNAC samples is by direct smearing or indirect smearing. And to conclude, FNAC is an effective, safe diagnostic tool for the evaluation of a variety of lesions. And image-guided FNAC offers better yield and accurate diagnosis. It enhances efficacy. ROSE enhances the efficacy of efficiency of FNACs, avoid repeat procedures, saves time in diagnosis, and is cost-effective. Quality measures are essential to sustain the standard and consistency in a diagnostic service. Coming to the next important procedure in cytology, that is pap smear. We all know about pap smear. It's practiced for cervical cytology, and the screening test, it's used as a screening test as well as a diagnostic test, mostly as a screening test for cervical cancer. By doing what is advantages is that it helps in reducing the morbidity and mortality due to cervical cancer. PAP test can detect the early stage of the you can detect the cancer in early stage through the PAP test. It's a simple, non-invasive, fast, cost-effective measure which can be taken, and diagnostic test for women, for symptomatic women with cervical cancer, and it can also be used as a surveillance test for carcinoma cervix, for treated cases of carcinoma cervix. So collection procedure, the smears can be collected from the vagina, exocervix, endocervix, and also in cases of postmenopausal bleeding, a suspicion of carcinoma of the body of the uterus, endometrial aspirate may be collected. So the smear preparation can be followed in by two ways. One is conventional cytology, or conventional PAP, as we say that, and the other one is liquid-based cytology, or what we call as LBC. So LBC is an improvised version. It's an improvement of the conventional PAP smear, and it helps to reduce limitations of the conventional cytology. There are some differences in the viewing of conventional and LBC, and you need to have more practice of the LBC in order to understand the smears which are produced by this technique. And there are certain advantages as well as certain disadvantages of LBC. Now, the advantages far outweigh the disadvantages. Advantages are it has better diagnostic accuracy, it decreases unsatisfactory smears, easier to examine, enhanced specimen preservation, and a lot more. And disadvantage is that not every setup will require an LBC. Conventional, for not a heavy duty setup or not a very big setup, the conventional PAP smear is very good, and you need not replace it with an LBC. But yeah, if it's required, then and you have sufficient load, then you can do an LBC as well, because this is more expensive. It requires specialized training, and there can be loss of architectural patterns, which you can only understand once you are used to this technique. Now, we use the TISDA system 2014 for reporting of our reporting. That is, this is our reporting format which we use for PAP test. And we have reporting formats for different types of specimens which are collected. And this is for PAP, which you can see over the screen. Now, a well-prepared and optimally stained smear looks something like this, which is very clear. There are certain criteria for calling the smear as unsatisfactory for evaluation. And these are some of them, wherein when you get scans, squamous cells, you have drying artifacts because the specimen has not been fixed properly, or you have obscuring hemorrhage, obscuring inflammation. So these are certain conditions in which you might not report on these conditions. And there are also criteria for satisfactory evaluation of a smear. These are some of the good smears which are satisfactory for evaluation and can be reported. These are some more examples. On the left-hand side, there down, you can also see a biopsy, which is showing some histo and cytocorrelation. These are some of the infections like Gardnerella vaginalis, actinomyces, and herpes simplex virus, which you can see on cytology, and this is how they look like. Now coming to LCIL, that is low-grade squamous intraepithelial lesion and neoplasia. So what is LCIL? So this is so basically the behavior of LCIL is very unpredictable. It has a high rate of regression. So 60% to 70% of the LCILs they regrade, but however regress. So however, there is some proportion of LCILs which transform to high-grade squamous intraepithelial neoplasm or squamous or directly to squamous carcinoma. So it is very important that these lesions should be followed up carefully. Then high-grade squamous intraepithelial lesions look something, as you can see in the above two pictures, and squamous cell carcinoma looks something what you can see in the below two pictures in a pap smear. Now, why is it so important to understand and examine these pap smears? Because it helps in a lot of management decisions in making decisions of the cervical lesions. So how do you manage when you call it NILM, that is negative for intraepithelial neoplasia of malignancy? You just follow up the patient or you just ask for the patient to come up to 3 to 5 years. Whereas if there are some infections or inflammation, then basically you need to treat and repeat the smear after the infection has subsided or the inflammation has subsided. Ascus is something in which you cannot ascertain the exact it is something which is lower than that of LCIL, but you cannot ascertain why is it so. So you repeat the smear after 1 year. Now, LCIL, I've already showed for high-grade lesions, you need to confirm it with a colposcopy or a biopsy. And then there is another category, which is atypical glandular cells or adenocarcinoma in situ or adenocarcinoma. If you get any of these, then you need to do a colposcopy examination or endometrial curettage or dilatation in curettage or a USG to see the kind of lesion it is, and further workup has to be done. So you see, I mean, the pap smear gives such a lot of information and it's a very simple tool to perform. So that's why it's very important. To summarize, cervical cytology is a simple, cost-effective technique, and it detects pre-malignant, malignant lesions and many benign, infective and reactive lesions. Cytology has the advantage of sampling wide areas and multiple lesions and is more acceptable compared to biopsies. Adequate sampling, optimal staining, meticulous screening, accurate interpretation and prompt treatment is necessary whenever there is a lesion on cytology, and suspicious lesions need to be biopsied. Now, coming to another important technique, which is not exactly cytology, but you prepare from cytology fluid that is known as a cell block. So what you do in a cell block is that you take the fluid, discard the supernatant, and add pool plasma to it. And after that, thromboplastin, and wrap it in a filter paper and process it just like a biopsy specimen. Now, what is the importance here is that since your process is like a biopsy sample, now on the right hand side you see a prepared slide which looks like just like that, and it is like a biopsy sample. Now you can do as many ISCs as possible on this smears, of course not as many as possible, the required number of IFCs is possible, and determine the type of tumor it is. For example, in case of carcinoma lung, if you get a metastatic pleural fluid and you want to determine that it is exactly carcinoma lung only, so what will you do? You will do a TTF1 and check whether the cells are exactly staining positive for TTF1. If it is staining positive for TTF1, that means the likely origin is the lung. So, so that is how you do ascitic fluid. You want to know that it's from the ovary. Do one Paxate, WT1, P53, and you'll get to know whether it's a serous carcinoma of the ovary, which is in the fluid. So this is how cell block helps us. Now, these are some of our department manuals which are very helpful in reporting purposes. Coming to the next section, that is surgical pathology. Now, surgical pathology would involve the whole. It would involve frozen section, histology, immunohistochemistry, and molecular pathology as well. So this will be a longer section because it will involve each and every part of it. Now, frozen section, as we all know, frozen section has become an indispensable part of a cancer institute. And we know we need a lot of intraoperative diagnosis during frozen. And what is the principle of frozen section? So any tissue contains 60 to 70% water. And if in frozen, what we do is that this water is converted into ice, making this tissue very hard, and it acts as an embedding media. On the right hand side, you can see a cryostat, which is there in our department and which can be used for frozen section cutting and cutting purpose. So this is the workflow which you can see in a frozen section. You have a tissue, you gross this. The specimen is grossed first, and then these are taken on chucks. These are the frozen second slide. You can see the frozen chuck. The tissue is taken on the chuck, and then it is put in the cryostat, and then further cutting is done. And the next step is the staining. And finally, the slides are prepared and it's viewed by the pathologist in the frozen section room. So the staining which is employed for frozen section are the toluidine blue and hematoxylin neosin staining. Now the toluidine blue has a very good property, that's a metachromatic stain, and so you can understand with the neoplastic lesions very it's easier to understand, and also it's a very quick stain. So we in our frozen section use both the stains, that is toluidine blue and hematoxylin neosin stain for our reporting, and the combination of the two is very good. So both the slides are there for each frozen section, that is the tol blue and the hematoxylin neosin slide. Now, when the specimen comes to our department or any pathology department, so it has to be received properly, and then it goes through a series of processes, which generally people who are not directly into the pathology field may not know about it, or may not know the nitty-gritties into it, unless and until we see it by ourselves. So what do we do in each of the steps? Just an overview so that we have an idea of how the slide is prepared. So first of all, transportation of the samples. This is very, very important and crucial steps, and which we all should know, because prompt fixation is, we all should know that prompt fixation is very important. Now, why is it so important? Because the specimen will likely to get autolyzed if it's not fixed properly. Now, small samples should be fixed in a fixative, which should contain 10% neutral buffered formalin in 1:20 ratio. And the big specimens, if they are removed late in the evening, if they are operated late in the evening, can be kept in Ziploc bags in a refrigerator, so that they are not autolyzed, because if they are not immediately transportable in a transportable state to the laboratory, then overnight they can be kept in a refrigerator. Immediate transport of the samples is a must in order to avoid autolysis. Otherwise, in normal conditions, it should be immediately transported to the lab. And so for frozen section, it should be transported in the fresh state. If it's from the OT, the specimens are to be transported, it should be transported in the fresh state, or else if there is a delay expected, then the surgeon should make nicks in the specimen, and it should be put in adequate amount of neutral buffered formalin, and it should be transported in big containers. It should not be narrow mounted containers. When putting core biopsy in the fixative should not be diluted, especially in core biopsy of the breast. So how do you send the specimens if you want to send it from an outside hospital to a main center or to a tertiary center? So there are certain do's for that, and these include a referring letter, which should be always written why the specimen, what was the thought process, and why the specimen or the tissue has been sent. The slides, tissue, block, specimen, it should be sent in appropriate conditions. The clinical history should always be attached. For neuropathology and bone tumors, the radiology report or the films should always be present, or should always be sent along with the other details, because they are very important in making a diagnosis. And the consult material should be accompanied by any pathology report. Now, why do we require the previous pathology reports or which the outside pathologist has reported? Is not to compare diagnosis or the see diagnosis, but to see the section key. The section key is very essential for a pathologist to make a point, because some sections may be from the tumor, the other sections may be from the margin. So if supposing the section number 5 is from the superior margin, it is involved, and number 6 is from the inferior margin, which is not involved. So, I mean, if there is a section key, it will help us, or if it will help any reporting pathologist to identify where the section is exactly from and make a decision properly, which will contribute to the treatment of the patient, because that if a superior margin is involved, that is likely to be get revised. So that part of that part is likely to get a revision. So that becomes very important. So section key helps the pathologist in several ways. And so wherever possible, paraffin blocks should be provided as much as possible, because immunohistochemistry would be required for many tumors. And if not immunohistochemistry, it may be predictive markers, prognostic markers. And therefore, it's good that the paraffin block is sent rather than only the HE slide. Now, coming to the next section, that is grossing. So grossing forms a very important role, although it's always the power of grossing is always underestimated, and people do not know the importance of grossing. But for staging of a tumor, it's not the reporting pathologist who would be able to stage the tumor at that level. This grossing is inadequate. So grossing is very important step. So what is grossing? Basically, you take sections from specific portions of the tumor of the specimen in order to stage the tumor, and so that the tumor is adequately sampled and staged properly. Now, for example, I'll give you the example of a breast tumor. Now, if you receive a mastectomy specimen and you need to look for all the proper sections, you need to take sections from the tumor, from the nipple areolar complex, from the skin, if it's an involved skin, from that particular area, the distance of the tumor from the base, and the representative section from there. If any of the sections is missing, and then also the lymph nodes, of course, all the lymph nodes need to be dissected properly. So if it's not done in an adequate manner, then the staging of the tumor or even the TNM would not be proper. So the sections have to be taken from the representative areas. If it's a lumpectomy specimen, then all the margins have to be adequately sampled. I mean, the superior, inferior, anterior, posterior, medial, lateral, and so on and so forth. So, so this is our grossing book of our own department, and where a detailed every detail about grossing technique is discussed. So coming to the next procedure, that is processing. Now, once the specimen is grossed, it's again kept for fixation, and it goes for processing. Now, for processing, the aim of the tissue processing is to embed the tissue in a solid medium firm enough for the tissue to support the tissue, and give sufficient rigidity to enable thin sections to be cut. So in order to do this processing, we have these processors in every pathology department. There will be these processors, and where a lot of so these are the steps of processing: fixation, dehydration, clearing, impregnation, paraffin embedding. So a lot of things take place. Sometimes you say that yes, the pathologist is not giving a report immediately, but the tissue goes through a number of steps before it really comes to a pathologist for a table for reporting. So these are the various steps, and every step has its own importance. You see a properly fixed breast tissue, how it looks, and if it's badly fixed, see, you cannot make out any morphological details properly. So it just spoils the entire thing. However good a pathologist reporting may be, or whatever it may be, they are not able to report if the specimen is not grossed properly, if it's not processed properly, if it's not fixed properly. So, and it's not transported properly. So every step is important. It's not just that reporting is important, but reporting is just one aspect of it. The other prior steps are as essential and crucial as reporting. Now, coming to the next step, that is embedding. Embedding is a process in which the tissue or the specimen are enclosed in mass of the embedding medium using a mold, and further then the block is cut and staining is performed. This on the left hand side, you can see an auto stainer, and finally the tissue is stained, and the slide becomes ready for reporting after mounting the slide. So this is how the slide will look like finally. And now we come to the ancillary techniques, that is immunohistochemistry. So, okay, so till now what we have seen in surgical pathology is frozen section and the basic hematoxylin and eosin staining of a slide. So that will help us to diagnose. But the diagnosis of cancer nowadays require a lot of things than it used to require before. Now, calling a sarcoma is not enough. You need to label that it's a Ewing sarcoma or it's a polydifferentiated synovial sarcoma. The treatment of a Ewing sarcoma will be different from a polydifferentiated synovial sarcoma. So that is the reason why we need to do immunohistochemistry. We need to do ancillary tests in order to come to a diagnosis. Now, coming to the immunohistochemistry section, now immunohistochemistry diagnostic, it has a role in diagnosis. We all know that immunohistochemistry is important for diagnosis. Now, let me show it to you through an example. Now, this is a slide in which on the left-hand side, you can see a lymph node with follicular hyperplasia, and on the right-hand side, you can see follicular lymphoma. Now, follicular hyperplasia, you can detect it morphologically. You can differentiate follicular lymphoma from follicular hyperplasia morphologically only. But to confirm that it's actually follicular lymphoma and follicular follicular lymphoma from follicular hyperplasia, we should just do a few IHCs to confirm. And one of the IHCs is CD20. Both the germinal centers of follicular lymphoma and reactive node will show CD20 positivity, but in follicular lymphoma, there will be more spillage of CD20 cells into the interfollicular regions. CD3 will be more in the interfollicular regions in reactive lymph node than in follicular lymphoma. BCL2 will be positive in the germinal center in a follicular lymphoma, whereas it will be negative in a reactive follicle. So thus, a couple of stains helps to differentiate a lymphoma from a follicular lymphoma. Now, we use a panel of IHCs just to show an example, a flowchart to show in non-Hodgkin lymphoma. We do much more than this, but then just a basic panel to give an understanding of how we select the panel of markers. So first we see whether it's a lymphoma or not morphologically, and then we do basic markers like CD20, CD3 to see whether it's a B-cell lymphoma, T-cell lymphoma. If it's a B-cell lymphoma, again, whether it's a high-grade lymphoma, low-grade lymphoma, we do understand morphologically also what it might be, but then we do additional stains to come to a conclusion as to what exactly, if it's a low-grade lymphoma, what exactly the lymphoma will be. If it's a high-grade lymphoma, what exactly the lymphoma will be. If it's a T-cell lymphoma, then again, for the division of it. Then you have histocytic markers, dendritic markers, molecular myeloid markers, which you also do if the lymphoma is these are histocytic sarcomas or dendritic cell tumors, myeloid sarcomas, and so on. So this is how we go one step after another when we see a case of non-Hodgkin lymphoma. What is positive is also very important, where the tissue has picked up the stain. For example, CD20 is intended for the cell membrane and not for the nucleus, whereas TDT, cyclin D1 are nuclear markers. ALK1 in lymphoma might be nuclear, but for carcinoma lung, if you do ALK IHC for carcinoma lung, then it would be, or adenocarcinoma lung, it will be granular cytoplasmic. So for different tumors also it differs, but more or less it will be the same for a particular. So we need to it's very important that we identify which region is picking up which marker. Now, coming to the next scenario, that is diagnostic, which I have labeled as diagnostic with a twist. Now, let us see what it is. What I want to say regarding this. Now, this is a scenario in which this was a 34-year-old male. The patient had hematuria for 2 months, did not have any comorbidities, and CT scan showed a tumor in the bladder wall, and patient underwent TURBT. So this was the HE slide which we received. And when we looked at the morphology, we saw that this might be a paraganglioma or a nested variant of urothelial carcinoma. And based on these differentials, we added a panel of markers: A1, A3, P63, HMW, CK, GETA3, synaptophysin, chromogranin, because these are the markers which we usually use for these two tumors. Now, to utter surprise, the A1, A3 was focally positive, GETA3 was negative, P63 was negative. These two markers are for for urothelial carcinoma. So these two markers were negative, which ruled out a urothelial carcinoma, and synaptophysin and chromogranin was also negative, which ruled out a paraganglioma. So these two differentials are out, and a third differential comes into the picture, which is that of a metastatic carcinoma. Now, metastatic carcinoma workup was done and some additional markers were added. Now, to utter surprise, CK7 was focally positive, CK20 was negative, and this was the ultimate surprise, which was Paxate, which comes in a couple of tumors like thyroid, kidney tumors, thymic tumors. These are Paxate positive. So now, since Paxate came out to be positive, we thought that we should add further thyroid markers. So we added TTF1 and thyroglobulin, and to our utter surprise, this tumor turned out to be thyroglobulin and TTF1 positive. Since this tumor was thyroglobulin TTF1 positive, that means that this must be a metastasis from a thyroid primary. But there was no history of any thyroid carcinoma. There was no symptoms on the thyroid. So what we asked for was a PET scan. And again, in the PET scan, as we had thought of, we could see that there was a hypermetabolic right thyroid nodule, and there was a hypermetabolic urinary bladder mass as well, which confirmed our diagnosis that this must be a metastatic carcinoma of the thyroid with a follicular pattern. But still now there was no confirmation, more confirmation to be done. So a USG neck was done, and a solid hypoechoic nodule was identified in the thyroid. And when FNAC was done, this turned out to be a papillary thyroid carcinoma. So this was the FNAC smear of the patient. Further, total thyroidectomy was performed, and a tumor was identified, which was confirmed on histology. And therefore, this was a patient of papillary thyroid carcinoma with metastasis to the bladder, which presented primarily as a bladder metastasis rather than as primary thyroid carcinoma. So in this way, we identified the primary site, and the patient would have received a completely different set of management had the patient been treated for a carcinoma bladder. But now the patient was treated for thyroid and received radioactive iodine, and had a better prognosis because obviously the prognosis and the follow-up and everything was good for the patient, because this was an entirely different tumor which had to be treated differently. And so IHC saved the case for us. Now, the third scenario, diagnosis. Is it diagnostic? Does IHC help us all the time? No, it is not always so. Now, let us see another scenario. Now, this was a 34-year-old gentleman with a recurrent history of right-sided nasal polyp for 7 years duration, and was referred to us with a diagnosis of clear cell adenocarcinoma. He underwent tumor resection on 3 different occasions, and his CT scan also showed a couple of things. And this was the morphology that we had received, and this was the nasal mass basically, which showed abundant cytoplasm and a very pattern, an alveolar type of pattern. But a number of tumors can have the same look. It can, so our differentials range from alveolar soft part sarcoma to picoma to metastasis of renal cell carcinoma to melanoma. So we did a whole a battery of markers for this patient, because this look can come in so many tumors. So our TFE3 was positive, HMB45, which we had done. TFE3 actually we had done for ASPS, which also comes into a host of other tumors like ASPS, picoma, paraganglioma can be TFE3 positive, and there are many other tumors as well, like even translocation associated RCCs can be TFE3 positive. HMB45 now comes in picomas, we know. It also comes in melanomas, but melanomas are generally TFE3 negative. So this tumor was HMB45 positive, TFE3 positive. Paxate, which was done for metastasis of RCC, was negative. SMA, again for picoma we had done, was negative. But alveolar soft part sarcomas, they are not known to be HMB45 positive. So we were again thinking, how can this, so it doesn't fit into any particular category. So what to do? So on reading the literature, we found that HMB45 positivity in ASPS can be attributed to cross reactivity, and which is false positive immunostaining. And now here in this particular case, special stains came to our rescue. Now, special stains are other ancillary tests, which are simple stains which you can find in, which can be started in any hospital with very basic setup. Now, what is this PAR stain? That is periodic acid shift. Now, ASPS, that is alveolar soft part sarcomas, they show some crystals, pink crystals in PAR stain, and these are also diastase resistant. So these periodic acid with diastase resistant. So this came out to be positive. So we confirmed that this was a case of alveolar soft part sarcoma. So here, the IHCs put us in trouble, but the special stain came for us rescue. So sometimes we need to combine us IHCs with even special stains, as you can see in this particular case. So it's not always the IHCs which give an answer. It's a combination of everything basically. So this is just to show a few tumors with the IHC panels for a few tumors and the origin also for these tumors. This is just a chart to show that. Now, coming to the next scenario, that is prognostic and predictive significance of immunohistochemistry. Now, the role of IHC is very big nowadays, and there is a theranostic new approach to the prognosis of tumors because of immunohistochemistry. Now, what are prognostic markers? The prognostic markers are patient or tumor characteristics that predict outcome independent of the treatment. And what are predictive markers? Predictive markers are patient or tumor characteristics that predict benefit from specific treatments, either in the terms of tumor shrinkage or survival. Now, some examples of predictive and prognostic markers. This is given in the list. Now, just to enumerate one or two prognostic and predictive markers. Now, IDH is done for tumors of the brain, glial tumors of the brain. So, astrocytomas are IDH positive tumors, and it connotes a better prognosis to the patient than tumors which are IDH non-mutant. So glioblastomas are IDH wild type, whereas the astrocytomas are IDH mutant tumors. And according to the CNS WHO 21 classification of CNS tumors, so it has a prognostic significance, and we do see in the JCs that IDH mutant tumors do particularly well than those which are IDH non-mutant tumors. So this is how prognosis is determined. HER2 positive breast cancers, now they are targets for anti-HER2 therapy. So likewise for different tumors, there are different prognostic and predictive markers which determine therapy and also determine prognosis. So these are very important nowadays because of targeted therapy, which is in practice nowadays. It's not only important to do IHCs, likewise we did for HE, we also have to maintain the quality of IHC. For that, we need to see the quality control of each stain, use control tissue for each particular IHCs, and see. So this is our master list for IHC controls that we have, and the positive control slide looks something of this sort, and this was for cytokeratin. We use different kind of control tissues for different positive as well as negative stains, and likewise positive control for certain predictive markers. We also use negative controls, and so we in the same slide we use the control and as well as the target tissue as well. And so this is how our slides look like. So we have controls on one side and the test tissue on the other side. So also some tissues like breast have internal control. So generally when we do the grossing of a breast specimen, what we do is we always take the tumor along with some normal tissue, so that the normal part, if it shows when we do the IHC, the normal part, if it shows ERPR staying and the tissue tumor doesn't show, that means that tumor is actually negative. And you can confirm this through the internal control as well. This is the IHC stainer, and calibration and maintenance of these instruments and machines is as vital and crucial as the interpretation of the stains are. Now coming to the next part, that is after immunohistochemistry, we come to the next part, that is molecular diagnostics. Now molecular diagnostics also nowadays it's a vast field, and it contains a battery of tests, and Now it includes in situ hybridization. Now in situ hybridization, what does in situ mean? In situ means in its original place, and hybridization means binding of the probes to the nucleic acids. Now in situ hybridization can be bright field in situ hybridization, or it can be dark field in situ hybridization. Now bright field in situ hybridization can be either chromogenic in situ hybridization, silver in situ hybridization, or dual color dual hapten in situ hybridization, depending on the material or the chromogen that we use for the target tissue. And then we have the fish, which we see in a dark room. And it is a molecular technique where fluorescent labeled probes are used to bind to the complementary sequences in the nucleic acid. Now, the scope of fish includes structural as well as numerical chromosomal alterations. However, genetic mutations cannot be identified by fish technique. Now, what are the applications? So applications, there are a host of applications. Just to enumerate a few diagnostic tests like EWS-R1, SYT, 1P19Q, LYC, MIC. These are mainly used for diagnostic purposes, and NMIC for prognostication. Predictive markers can be HER2, ALK, ROS, PCR, ABL. These are for predictive purposes. This is a fluorescence picture of a fluorescence microscope, which we have in our department. Then, so this is an image of the fish. On the left-hand side, you can see a non-amplified case, whereas on the right-hand side, you can see the green signals, multiple green signals, and only one red signal. So normally, you generally see 2 red and 2 green signals have fused together. That is the normal signal pattern. But when you see more, when the number of green, that is the target HER2 locus, becomes amplified, then you see something which you can see in the right hand side. So that is a case of an amplified HER2. Just to show an example of rearranged versus non-rearranged. So negative, non-rearranged, I've already said how the normal will look like. For the rearrangement, for EWS-R1 rearrangement or for ALK rearrangement, you'll see a split signal where you will see that the red and green are not fused together. One signal may be fused, the other signal may move 2 signal diameters or 1 signal diameter apart from one another. And in that scenario, we call that as rearranged. Now, there are various diagnostic applications. Now, for example, in a case of round cell tumor, first of all, you obviously see morphologically that's a round cell tumor. Then you do immunohistochemistry. For Ewing sarcoma, there it will be MYC2 positive, FLI1 positive, FLI1 positive, NKX2.2 positive. Synovial sarcomas will be EMA positive and TLE1 positive. And then rhabdomyosarcoma will be desmin, myogen, and myo-D1 positive. However, there can be some scenarios in which it's a poorly differentiated synovial sarcoma, which looks very much like a Ewing sarcoma on morphology, and you cannot very much differentiate. And then there comes the role of molecular diagnostics, and EWS-R1 rearrangement will help to differentiate Ewing, to call this as a, if it comes out to be rearranged for EWS-R1, then it is likely to be a Ewing sarcoma. Whereas if it's SS18 positive, it's likely or rearranged, it is likely to be a synovial sarcoma. And for PAX, for rhabdomyosarcoma, we generally do fragment analysis of PAX3, PAX7. So every technique has its own advantages and disadvantages. So some of the advantages of fish are that it's a relatively more economical technique than it has a high setup cost. But then if you see techniques like NGS and all those, it is relatively economical than that. It's it's not very rapid, but yes, easier to perform than many other molecular techniques, and can address heterogeneity and can be performed in relatively scant tissue. Of course, it has its own cost and needs technical expertise, and only known aberrations can be detected by this technique. Coming to the next technique, that is the polymerase chain reaction. So polymerase chain reaction is an in vitro exponential amplification of a DNA of a region of the DNA whose sequence is known, or which lies between 2 regions of a known sequence. And there are various steps of polymerase chain reaction, which include denaturation, annealing, extension, and then followed by gel electrophoresis and staining and visualization. You have a template where you see in the template you generally have the DNA ladder, then you have the samples, which may be A, B, C, whatever the number of the sample will be, and then you have positive controls, you have negative control, and you have reagent control. If you see a band at the region of the positive control, that is likely that that sample is positive. So there are various variations of PCR as well, and each has its own significance. A reverse transcriptase PCR is something where the RNA is converted to cDNA and is subjected to PCR. And real-time PCR is something where the amount of accumulated product is measured at the end of each cycle and seen and done in real time, and is used for mutation detection, therapy monitoring, gene expression profiling, etc. Coming to the next technique is sequencing. So determining the precise sequence of the nucleotides in a stretch of DNA is very important, and detection of the various genetic alterations like point mutations, deletions, insertions, polymorphisms, complex mutations, all these can be detected by means of sequencing. So sequencing can be, the most basic form of sequencing is the Sanger sequencing, and it uses the chain termination using dideoxynucleotides for this procedure. And so the workflow is as follows. Purify the PCR product, set up for sequencing reaction, perform the cycle sequencing. Cycle sequencing product is used for purification, resolve the fragments, and then the sequence is read. So this is an example of a heterozygous point mutation for IDH. And so this is a kind of point mutation. And so IDH R132H can be detected through IHC. But if it's IHC negative, then we need to subject it to sequencing for both IDH1 and IDH2. There is no IHC for IDH2, and we need to do sequencing in order to confirm that the negative is exactly negative, and we do sequencing in that particular case. So in this particular case, this is positive for a point mutation. And as I've already said, IDH, it helps in prognostication of the patient, and is very important. Therefore, it is very important to identify this mutation in gliomas. Then frame shift mutation, very common in KIT mutations, and usually these frame shift mutations are produced as a result of some deletions, insertions, or some due to some factors, and it leads to the complete disarray of the sequences lying ahead of the of that particular region which is inserted, deleted, and this is how the frame shift mutation looks like. Now, every technique, again, as I said before, has its advantages and disadvantages. So advantage is that it's relatively cost-effective, workflow is easy, and it's a gold standard. And limitations are that it has lower sensitivity and not cost-effective for multiple alternating testing procedures. And then if it's not working, in some cases, we need to resort to next generation sequencing because every technique has its limitations. And if we know that a particular test cannot be performed and we need to see a large panel of genes together, then we need to go to next generation sequencing. Now, this is just a table to show the different types of molecular tests which are done, the modality, why it is done for. Some are done for diagnostic, some are for predictive, prognostication, and the different types of tumors in which these are done. So coming to the last case of this session, which I want to show you, wherein it's a combination of all the techniques together. So this was a 61-year-old lady who had presented with a left axillary lump of 8-month duration, for which she underwent FNAC and excision biopsy 3 years back and was reported as an eccrine spironoma elsewhere. 4 months later, she noticed a breast lump, and clinically the breast mass measuring 6 by 6 centimeter was noted in the left upper quadrant with a 5 centimeter sized axillary nodal mass, and a mammography confirmed that she had that breast mass, and you can see the mammography over there. And this was a tumor like. Now, in a 61-year-old lady, we generally expect that the tumor will be an invasive breast carcinoma if it's a breast mass. That's the usual scenario that we get day in and day out. But this turned out to be completely different. It was like a round cell tumor, which we see in the younger age group. And the breast is completely unusual location for something of this sort. Now, this lady For this, this was on morphology. This was nothing but a Ewing sarcoma. But to call it a Ewing sarcoma at the age of 61 was very difficult. We did IHCs, which did show markers for Ewing sarcoma like CD99, Fly1, A1, A3, NKX 2.2, which all were positive. But we still wanted to confirm it by a FISH test. And we did EWS R1 rearrangement, where we could see the split signals, and this was confirmed case of Ewing sarcoma. And so this was a case of a lady with a 61-year-old lady with the breast marks with Ewing sarcoma. Very unusual indeed. So this is how all the ancillary techniques together with histology helps in making a diagnosis. So I come to the end of the conclusion. The end of the presentation, and I would like to acknowledge Dr. Gauri, Salim, Neena Madam, Dr. Vinayak, and Rita Madam for providing me many of the pictures in the presentation, and also with the molecular diagnostics. So it's a collective responsibility of all of us to bring in everything together to the table. It's not a one person's job. So right from the person who's receiving the sample, who's sending the sample, the resident or the consultant who's grossing the sample, the technician who is doing all the processing, staining, and finally the reporting pathologist. Every person is important, and everyone has his or her own contribution to it. Thank you very much.
Thank you, Doctor, for the wonderful session. So we have a few questions from the audience. So I've just posted it in the chat box. Doctor, you're mute.
I'm so sorry. I'm so sorry. So, okay, so markers for prognostication head neck cancers. Yes, P16, that's used, and any other markers for carcinoma prostate diagnosis. Yes, we do use Amicar, we use PSA, and NKX, that is also used for prostate. And what are screening tests? Okay, so for screening tests are those tests which are like, for example, as I said earlier, pap test. It's a kind of screening test. FNAC, that can be, I mean, not FNAC, it's an invasive procedure, but yes, pap test, it's a screening test. So now why is it a screening test? Because you can, from a larger sample, you can see, it's a simple and easier to perform test, and you can screen a large number of patients together, and I mean, even if the sample is negative, we can keep a close follow of the patient. Whereas if you do a biopsy, it's an invasive procedure. So directly not do a biopsy in the first place. First, you need to screen the patient that there is something or you're suspecting something. So for tumors which are preventable like carcinoma cervix, you do a pap test, and that's a kind of screening test. So this is an example of a screening test, which is high sensitivity and low specificity, basically. So sensitivity of a screening test is high. Can I have the next question, please?
There are no questions from the audience.
Okay. Okay.
Dr. Deepa, over to you.
Thank you, Abhilash. Once again, thank you, Dr. Ekta, for your time and teaching us on the overview of lab investigations in cancer diagnosis, tumor markers, cytology, histopathology, with beautiful pictures showing us the many different kinds of cells, including teaching us from the case scenarios. To all our participants, we hope you enjoyed. If your questions were not answered, please do not worry. On the Omnicurus platform, there is a tab, Ask an Expert. Here your question can be posted and our experts will be able to check and answer them. Next fortnight, we will have yet another Power Pack lecture by Dr. Karthik from the Department of Surgical Oncology from Sri Venkateshwara Institute of Cancer Care and Advanced Research, who will teach us on the role of surgery in cancer treatment, which will be on 29th of October, 2022. So see you all at 3 p.m. on the 29th of October. Happy Diwali to all of you and have a very good weekend, everyone. Thank you, Dr. Ekta.
Thank you.